Okay, good morning, guys. Today we are going to continue with our with the last chapter in the chest imaging from the fundamentals of diagnostic radiology on the diseases of the pleura and chest wall and diaphragm. We'll start from the pneumothorax. Will be to the end of the chapter. It will be presented by our colleague, Dr. Kania Hussein. May she start? Thank you.
Good morning, everyone. I will start by pneumothorax. Pneumothorax results from air entering the pleural space. It's divided to either spontaneous or traumatic. Spontaneous, either primary or secondary. Traumatic, iatrogenic or non-iatrogenic. We mean by primary, there is no identifiable etiology. Secondary, underlying parenchymal lung disease. Patient will present with sudden onset of dyspnea and pleuritic chest pain. Primary spontaneous pneumothorax. It occurs, it's familial, mostly in young or middle-aged, thin, tall men. Affected patient may have bleeps or bulli in the lung apices that are responsible for the development of recurrent pneumothoraces. Treatment is by closed tube drainage with thoracoscopic embolectomy reserved for recurrent episode or persistent ear leak. Other subject is secondary spontaneous pneumothorax. The most common cause is chronic obstructive pulmonary disease, then asthma or the performance of Valsalva maneuver, crack cocaine or marijuana smoking, transvaginal childbirth may cause spontaneous pneumothorax. Also cystic lung changes in sarcoidosis, Langerhans cell histiocytosis, and lymphangiomyomatosis, necrotizing pneumonia or lung abscess, especially lung abscess that caused by gram-negative or anaerobic bacteria. Tuberculosis also can lead to pneumothorax. Metastasis also is one of the secondary causes to pneumothorax. Primary malignancies that lead to pneumothorax, mostly sarcoma, osteogenic sarcoma, lymphoma, and germ cell malignancy. Marfan syndrome.
Not primary malignancies. What are the types of metastasis that cause pneumothorax?
Yes.
Osteosarcoma. Osteosarcoma is not a primary malignancy of the chest. It's a metastatic tumor to the chest that commonly causes osteosarcoma.
Primary. Marfan syndrome is the most common connective tissue disease producing pneumothorax. Not uncommonly, patients with acute respiratory distress syndrome develop small peripheral cystic air spaces which can rupture into the pleural space and cause pneumothorax. We have a rare type which called catamenial pneumothorax, which occur during menstruation, affect women in their fourth decades, and caused by the cyclical necrosis of pleural endometrial implants, so ear leak between the lung and pleura. Rarely, ear may enter the peritoneal cavity and gain access to the pleural cavity via diaphragmatic defect. This cause mostly right-sided pneumothorax and indicate a key role for right-sided diaphragmatic defect. The pneumothorax tend to be small and resolve spontaneously, and it's managed by preventing menstruation with the administration of oral contraceptive. Here we have chest X-ray in a patient with a history of sarcoma. This I mean by spontaneous secondary pneumothorax. Bilateral spontaneous pneumothorax, and in other coronal reformatted chest CT confirms the pneumothorax and show thin wall cavitary nodule reflecting metastasis. So this is a secondary spontaneous pneumothorax. We have traumatic pneumothorax. Trauma is the most common cause of pneumothorax, either penetrating or blunt chest trauma. Penetrating like gunshot, knife wounds to the chest, upper abdomen, central line placement, thoracentesis, transbronchial and percutaneous needle biopsy. Blunt also may cause pneumothorax. In patients with rib fractures, the free edge of the fracture rib can project inward to lacerate the lung and cause pneumothorax. Radiographically, pneumothorax, how we can see it in upright radiography, I mean in erect chest X-ray, non-dependent lucency that parallels the chest wall and displays the visceral pleural line medially. And in supine patient, in cases of emergency of intensive care unit, pneumothorax can be undetectable as air in the pleural space rises non-dependently and creates increased lucency over the lower thorax and upper abdomen. And also not uncommon in trauma patient to detect a small basilar pneumothorax overlying the lower chest, which is not evident radiographically. This is a supine portable chest X-ray in patient with severe blunt chest trauma. We see here abnormal lucency over the upper right abdomen and deep right lateral costophrenic sulcus. The next image is after chest tube. We see here the pneumothorax was resolved. What are the signs of pneumothorax? We have 3 signs. First, deep sulcus sign, which appear on supine radiograph, include hyperlucent upper abdomen, particularly on the right side, over the normally dense liver. Okay. This is the deep sulcus sign. Hyperlucent upper abdomen, especially on right side over the normally dense liver. Second, we have the double diaphragm sign. Here we see the double diaphragm sign. We have another sign called epicardial fat pad sign. It occurs mostly in left pneumothorax and unusually sharp heart border. On CT, pneumothorax is identified by non-dependent lucency over the lower anterior thorax because the patient is lying on supine. Tension pneumothorax, it's a critical, mostly result from iatrogenic trauma in mechanically ventilated patient, from a check valve pleural defect that allows air to enter but not exit the pleural space. So the pleural air collects and complete collapse of the underlying lung and impairing venous return to the heart. Patient present with tachypnea, tachycardia, cyanosis, and hypotension. Radiographically, the involved pneumothorax is expanded and hyperlucent with medially retracted lung, ipsilateral diaphragmatic depression or inversion, and contralateral mediastinal shift. It's important to remember that contralateral mediastinal shift from pneumothorax does not invariably indicate tension, and tension pneumothorax remain a clinical diagnosis. Immediate evacuation of the pleural space should be performed with a needle catheter or a large bore thoracostomy tube. This is an example of tension pneumothorax with all signs that I mentioned: hyperexpanded, hyperlucent, and medially displaced lung, shift of the inversion of the diaphragm, shifting of the mediastinum to the left side.
By the way, keep in mind, since tension pneumothorax is a clinical diagnosis, it's not a radiological diagnosis. You rarely see X-rays of tension pneumothorax. Usually it happens and treated before, and there is no time for referral to the radiology department and X-ray and report. They just detected clinically and treated at the same time. Immediately, exactly.
We have another subject, focal pleural disease. First, localized pleural thickening from fibrosis is usually the end result of peripheral parenchymal and pleural inflammatory disease, mostly pneumonia. Others include pulmonary embolism with infarction, asbestos exposure, trauma, prior chemical and drug, pleurodesis. Second, pleural calcification, mostly unilateral, and involve the visceral pleura, usually the result of prior hemothorax, empyema, example TB. Asbestos exposure can cause bilateral multifocal calcified parietal pleural plaques, and visceral pleural calcification from pleural hemorrhage or infection are indistinguishable radiographically. It's initially punctate, then becomes sheet-like. So CT is useful in characterizing pleural calcification. The presence of fluid within the calcified pleural layer seen on CT suggests active empyema that's most often due to TB. Here we have unilateral calcification of the pleura caused by tuberculosis. As we mentioned, it's mostly unilateral, but asbestos can cause bilateral calcification and mostly involve the visceral pleura. Pleural mass, usually benign, such as lipoma, or loculated pleural fluid can mimic a pleural mass radiographically. Thoracic lipoma may arise in the chest wall or subpleural fat. Subpleural lipomas produce a pleural mass and can change shape during respiration or with change in patient position because of their pliable nature. Here we have pleural lipoma in a patient with left anterior lateral pleural based mass with a homogeneous fatty attenuation. I mean by minus 30 to 100 Housefield unit. Fourth, localized fibrous tumor of the pleura. It's uncommon, mostly benign, 80%, and 50% will recur after resection. These appear as well-defined spherical or oblong masses that arise from the subpleural mesenchymal cell. Occasionally, they are attached to pleura by a narrow pedicle, and if seen, it's pathognomonic. Change in intrapleural location with change in patient position, such as lipoma. CT usually show a smoothly marginated pleural-based soft tissue mass with either uniform soft tissue attenuation or inhomogeneous enhancement caused by areas of necrosis. An association between the localized fibrous tumor of the pleura and hypertrophic pulmonary osteoarthropathy and hypoglycemia is recognized, but there is no association between it and asbestos exposure. In chest X-ray, we have a smooth mass in the lower right lateral chest with obtuse superior and inferior angle. In CT axial, we have a sharply defined soft tissue mass with tapered obtuse margin typical of pleural mass. Regarding diffuse pleural disease, first we have diffuse pleural fibrosis, or what's called fibrothorax. Is defined as pleural thickening extending over more than 1/4 of the costal pleural surface. 1/4 mostly result from the resolution of the exudative pleural effusion, including asbestos-related effusions, empyema or hemothorax. It may also be seen as subpleural extension of the diffuse interstitial fibrosis. It can encompass the entire lung and produce entrapment. Here we have diffuse pleural fibrosis. Axial CT show a right pleural effusion, and after repeating the CT, years later, we see pleural thickening and extrapleural fat, hypertrophy, and volume loss in the right hemothorax. We should note the sparing of the mediastinal and pleural surface, and this is typical for benign pleural disease, because if it involves the mediastinum, it means it's malignant. Pleural malignancy. Metastatic disease to the pleura commonly cause irregular or nodular pleural thickening plus pleural effusion, mostly. The malignant tumor that metastasize to pleura include adenocarcinoma of the lung, first, second breast, third ovary, then kidney and GI tract. Malignant mesothelioma is seen in almost exclusively in asbestos-exposed individuals. Malignant pleural disease is most often caused by one of the four conditions, either metastatic adenocarcinoma or invasive thymoma, thymic carcinoma, mesothelioma, and rarely lymphoma. How we see pleural malignancy? Radiographically, multiple discrete pleural masses or nodular pleural thickening. The pleural lesions are often obscured by associated malignant pleural effusion. Contrast-enhanced CT can distinguish solid mass from loculated pleural fluid and can show discrete pleural mass or thickening in patients with large effusions. In contrast to benign thickening, malignant pleural disease is more likely when the pleural thickening on CT is circumferential and nodular, greater than 1 cm in thickness, and or involve the mediastinal pleura. Chest wall invasion by pleural tumor, seen as rib destruction, soft tissue infiltration of the subcutaneous fan and musculature, is better appreciated on CT or MRI than on plain film. The diagnosis of malignant pleural disease is made by cytological examination of the fluid obtained at thoracocentesis. I will talk about asbestos-related pleural disease. As we know, prolonged exposure to asbestos can result in a variety of pleural and pulmonary disorder. Either benign, which is the most common presentation, include pleural plaques, pleural effusion, and diffuse pleural fibrosis, or malignant, such as malignant mesothelioma. Pleural plugs are the most common benign manifestation of asbestos inhalation, develop 20 to 30 years after the initial asbestos exposure, and are more frequent with increasing length and severity of the exposure, found on the parietal pleura, mostly over the diaphragm and lower posterolateral chest wall. The mediastinal pleura and the costophrenic sulci are characteristically spared. The plugs are discrete, bilateral, slightly raised, 2 to 10 mm thick, foci of pleural thickening. Punctate or linear calcification within the plugs is common. Visceral pleural plugs, seen as discrete flat region of pleural thickening within the major fissure on high-resolution CT, and are most commonly associated with interstitial fibrosis. Most patients with isolated asbestos-related pleural plugs are asymptomatic. Detection of plugs on conventional radiography is best performed with 45-degree oblique views that profile the anterolateral and posterolateral plugs. CT and high-resolution CT study are extremely sensitive in detecting the calcified and non-calcified plugs and can distinguish plugs and diffuse fibrosis from subpleural fat deposit that may mimic pleural disease on conventional radiography. Plugs are mostly bilateral, and if it's unilateral, it's mostly on the left side.
Plus can involve visceral?
Sorry?
No. Why is it here?
in the book it's written
Just parietal.
just parietal. بعدين اكو كمان صغير يعني
Visceral
visceral.
in interstitial.
Yeah, so let's say very rarely to involve the visceral. The vast majority of the cases is parietal.
Here we have chest X-ray, PA, and lateral view. In 64-year-old man shows bilateral diaphragmatic and anterolateral pleural plugs reflecting prior asbestos exposure. Here plugs, and in the lateral also, over the diaphragm. Pleural effusions occur 10 to 20 years after the initial exposure and is the earliest manifestation of asbestos-related pleural disease. It is dose-related, usually small, unilateral or bilateral, and exudative and may be bloody. Resolves spontaneously up to 1/3 recur, and some patients develop diffuse pleural fibrosis. Diffuse pleural thickening or fibrosis may follow asbestos-related pleural effusion or result from the confluence of the plugs. Diffuse asbestos pleural thickening is defined as smooth, flat pleural thickening extending over 1/4 of the costal pleural surface and involve both the parietal and visceral pleura and can result in symptomatic restrictive lung disease. CT and high-resolution CT are useful to determine the extent of pleural thickening, involvement of the fissures, and to detect the underlying fibrotic or emphysematous lung disease. Diffuse pleural fibrosis can result in symptomatic restrictive lung disease. We have malignant asbestos-related pleural disease, what's called malignant mesothelioma. It is rare, and like other pleural and parenchymal manifestation of asbestos, it's not dose-related. Often occur 30 to 40 years after the exposure. Malignant mesothelioma may also develop after minimal exposure. Distant metastases are not uncommon and often appear radiographically as thick, more than 1 cm, and nodular diffuse pleural thickening, calcification, or rarely ossification in 20%. A pleural effusion is often present. Malignant involvement of the mediastinal surface may prevent contralateral mediastinal shift despite the extensive pleural tumor volume and effusion, a finding that may help distinguish mesothelioma from metastatic disease. CT is the imaging modality of choice in evaluation of malignant mesothelioma and extent of pleural involvement and invasion of the chest wall and mediastinum. Adenopathy is seen in ipsilateral hilum and mediastinum in 50% of patients, and median survival from the time of diagnosis is 6 to 12 months. Here chest X-ray show nodular right pleural thickening, and this is coronary formatted contrast enhanced CT, shows circumferential nodular right pleural thickening with the extension into the right oblique fissure. We will come to chest wall lesion. I'll start by soft tissue, then bony lesion. Regarding soft tissue, we have congenital absence of pectoralis muscle. It results in hyperlucency of the affected hemithorax on frontal radiography. Poland syndrome is an autosomal recessive disorder characterized by unilateral absence of sternocostal head of pectoralis major and ipsilateral syndactyly and rib anomalies may be associated with aplasia of the ipsilateral breast. Patients who have had a mastectomy will also have unilateral hyperlucency. Skin lesions such as moles, nevi, warts, neurofibromas, and accessory nipple may produce a nodular opacity on frontal radiograph that mimics a solitary pulmonary nodule. So, examination of the skin surface should be performed in any patient with a new nodular opacity seen on chest X-ray, and then repeat the radiograph with a marker over the lesion. Chest wall abscess may present as localized, painful, fluctuant subcutaneous masses. Staphylococcus and Mycobacterium are the most common organisms responsible. Chest radiograph demonstrate a poorly defined opacity on frontal radiograph when the abscess involves the anterior or posterior chest wall. CT show a localized fluid collection with enhancing wall and used to determine the location and extent of collection prior to open drainage. This example of Poland syndrome. We see hyperlucency in the left side due to absence of the pectoralis major. Soft tissue neoplasm of the chest wall are rare. Most common benign neoplasm is lipoma, which may be intrathoracic or extrathoracic, or they may project partially within and outside the thorax, and then called dumpel lipoma. CT shows sharply circumscribed mass of fatty density, whereas MR show characteristic high and intermediate signal intensity on both T1 and T2 respectively. It means it's high in T1 and intermediate on T2. A desmoid tumor is a rare, histologically benign, but has a tendency for local invasion, mostly in the abdominal wall musculature of multiparous women, but may arise in the chest wall musculature following local trauma. Hemangioma are uncommon, often indistinguishable from other soft tissue tumor, but radiographically the recognition of phlebolith, hypertrophy of the involved bone, or identification of vascular channel on contrast-enhanced CT or MR study suggests the diagnosis. Fibrosarcomas and liposarcomas are the most common malignant soft tissue neoplasm of the chest wall in adults, and they appear as soft tissue mass often associated with bone destruction. This is an enhanced CT scan shows sharply circumscribed homogeneous fatty mass in the left pectoralis and rhomboid major muscle. Examples of lipoma. We have other tumor of soft tissue called Askin tumor. It's a primitive neuroectodermal tumor of the chest wall. It's a rare malignant neoplasm arising from the chest wall of children and young adults, which arise from primitive neuroectodermal rests in the chest wall. They are very aggressive with a high mortality rate. This contrast-enhanced CT in 32-year-old man demonstrates left pleural mass and with adjacent involvement of the rib and associated pleural effusion. After repeating the CT 1 month later, we see enlargement of the mass with progressive rib involvement and large pleural effusion with contralateral mediastinal involvement. It's very aggressive. We will come to the bony thorax. I'll start by congenital anomalies. The most common congenital anomalies of the ribs are bony fusion and bifid ribs. They have no clinical significance. Intrathoracic ribs are extremely rare when an accessory rib arises from vertebral body or posterior surface of rib and extend inferior laterally into thorax, usually on the right side. Osteogenesis imperfecta and neurofibromatosis may be associated with thin, wavy ribbon ribs. Cervical rib, it's common relatively, which arises from the seventh cervical vertebral body. Usually it is asymptomatic, and although in minority of individuals with a thoracic outlet syndrome, the rib or associated fibrous band can compress subclavian artery and produce second weakness and swelling of the upper extremity, then surgical resection will relieve the symptom. Here we have cervical rib bilaterally, but they are asymmetrical. Rib notching. We have inferior and superior rib notching. Inferior one is the more common than the superior and caused by enlargement of the structures that lie in the subcostal groove, either nerve or artery or vein. It predominantly affects the posterior aspect of the rib bilaterally. The most common cause of bilateral inferior rib notching is coarctation of aorta distal to the origin of the left subclavian artery. Unilateral right-sided notching occurs when the coarctation is proximal to the left subclavian artery. So, if the coarctation was distal to the origin, it causes bilateral inferior notching. And if it is proximal to the left subclavian artery, it leads to unilateral right-sided notch. Coarctation may produce a unilateral left rib notching when the aortic narrowing occurs proximal to an apparent right subclavian artery. So the notch, if it's in the left due to a right subclavian artery, and if it's to the right due to left subclavian artery.
What do you mean by aberrant right subclavian artery?
يعني مقطوع.
It's not cut. The right, usually the aortic arch, all of them rise from the aorta. Usually you have the brachiocephalic, which gives common right and common carotid. Okay, if the right subclavian arises after the left subclavian, he said common right common carotid, left common carotid, subclavian, then right, aberrant. It's from the abnormal origin. Okay, so the coarctation is before the aberrant right, so that all the proximal to the coarctation, all of them will be enlarged, while the distal one will be normal.
Small. The first two patients with aortic coarctation develop rib notching gradually. It is most common in adolescents and rare in children younger than 7 years. The first two ribs are uninvolved because the first and second intercostal arteries arise from superior intercostal branch of costocervical trunk of subclavian artery and therefore do not communicate with the descending thoracic aorta. Other causes for notching are aortic thrombosis, Takayasu-aortitis, congenital heart disease, and superior vena cava obstruction. Additional cause of unilateral inferior rib notching include subclavian artery obstruction, surgical anastomosis of the proximal subclavian artery to the ipsilateral pulmonary artery. Multiple intercostal neurofibromas in neurofibromatosis type 1 are most common non-vascular cause of inferior rib notching. Superior rib notching is much less common and mostly due to paralysis. Other etiologies include rheumatoid arthritis, SLE, and rarely marked tortuosity of the intercostal arteries from severe long-standing aortic obstruction. Here we have inferior rib notching Rosler's sign, either enlarged collateral vessels, coarctation of aorta, interrupted aortic arch, or subclavian artery obstruction. Takayasu disease, Baluk-Towsing shunt involve only upper two rib space, AV malformation of the chest wall, superior vena cava obstruction with enlarged venous collaterals and pulmonary AV malformation. Neurogenic tumor such as schwannoma or neurofibromatosis type 1. Neurofibromatosis type 1 can cause inferior and superior rib notching. Here we have inferior rib notching. Trauma. Rib and costal cartilage fractures may result from blunt or penetrating trauma. An acute rib fracture is seen as a thin vertical lucency and or malalignment of the superior and inferior cortices of the rib. The tendency to affect the posterior lateral aspect of the ribs explains the utility of obtaining ipsilateral posterior oblique radiograph for suspected fractures. In any patient with acute rib fracture, search for associated pneumothorax, hemothorax, and pulmonary contusion or laceration. Since the first three ribs are well protected by the clavicle, scapulae, and shoulder girdle, fracture of these ribs indicates severe trauma and should prompt a careful evaluation for associated great vessel and visceral injuries. Fracture of the lower 10, 11, and 12 rib may be associated with injury to liver or spleen. Severe blunt trauma or rib cage in which multiple contiguous ribs are fractured in more than one place is termed flail chest. This results in free segment of the chest wall that moves paradoxically inward in inspiration and outward on expiration. Multiple contiguous healed rib fracture, particularly if bilateral, should suggest chronic alcoholism or prior motor vehicle accident. Neoplasms of the chest wall. Osteochondroma are the most common benign neoplasm of the rib in adult, and chondrosarcoma is the most common primary rib malignancy. So osteochondroma the most common benign, and the chondrosarcoma the most common primary rib malignancy. Most common metastatic lesions to the ribs are from bronchogenic and breast carcinoma. Expansilytic rib metastases are seen most commonly from renal cell and thyroid carcinoma, and sclerotic rib metastases most commonly seen in breast and prostatic carcinoma. This PA chest radiograph in 37-year-old woman with 3-month history of right shoulder pain demonstrate right apical extrapulmonary mass, and in CT scan reveals bone forming mass arising from the right third costotransverse junction with erosion of the adjacent vertebral body. This is chondrosarcoma of the rib. Example for plastic bone metastasis: a chest radiograph shows sclerotic expansile change in two contiguous right posterior ribs and the mid-thoracic spine. We have here coronal CT through the ascending aorta shows speculated right upper lobe nodule reflecting patient's primary non-small cell lung cancer. Costal cartilages. Ossification of the costal cartilage is a normal finding on frontal chest radiograph in adults. Female costal cartilage ossification involves central portion of the cartilage extending from the rib toward the sternum in shape of a solitary finger, whereas in male, the costal cartilage ossification involves the peripheral portion of the cartilage and has appearance of two fingers and peace sign. This typical pattern of male and female costal cartilage ossification are seen in 70% of patients and do not apply to the first rib.
So you see on this one, on the left side, this is the female type of the male type of ossification.
Yes.
It's like two fingers.
Yes.
This side,
Yes.
okay. While on the right
Woman.
side, it's the
Central.
female type of
Yes.
ossification. The central of the line.
Yes, central in female and peripheral in male. Scapula. Springle deformity. It's a congenital anomaly in which the scapula is hypoplastic and elevated. The association of springle deformity with an omovertebral bone, fused cervical vertebrae, hemivertebrae, and kyphoscoliosis and ribs anomalies is termed Klippel-Feil syndrome. This is example for springle deformity.
This Klippel-Feil syndrome is a common board question. So keep it in mind. Give us a lot. Oh, findings, which one of them is correct, which one is wrong.
A winged scapula is identified when the scapula is superiorly displaced from its normal position and the inferior portion is posteriorly displaced from the chest wall, thereby foreshortening its appearance on a frontal radiograph. This deformity results from disruption in the innervation of serratus anterior muscle that maintain the scapula against the chest wall. Metastatic disease to the scapula is recognized by presence of lytic destructive lesion. Bronchogenic and breast carcinoma are the most common primary malignancies. Thoracic spine. Numerous thoracic spine abnormalities are visible on chest radiograph. Congenital anomalies such as hemivertebra, butterfly vertebra, spina bifida, and scoliosis can be seen on well-penetrated frontal radiograph. Vertebral compression fractures caused by trauma, osteoporosis, metastasis are best seen on lateral radiograph and may produce exaggerated kyphosis. Large bridging osteophyte may mimic a paraspinal mass on frontal radiograph or pulmonary nodule on lateral film. Vertebral osteomyelitis is seen as destruction of the vertebral bodies and intervertebral disc, often associated with paraspinal abscess. Chronic anemia in patients with thalassemia major or sickle cell disease may result in prevertebral or paravertebral masses of extramedullary hematopoiesis, which represent herniated hyperplastic bone marrow. Sickle cell anemia produces a characteristic appearance of H-shaped or Lincoln log vertebrae on lateral chest radiograph, which is pathognomonic of this disease. Similarly, a regular jersey appearance to the thoracic spine or lateral chest film will suggest renal osteosclerosis. This is H-shaped vertebra which is seen in sickle cell anemia in AP and lateral chest in AP and lateral X-ray. Clavicle. The clavicle is involved in cleidocranial dystosis in which there is partial or complete aplasia of the clavicle. The distal third of clavicle is commonly fractured in blunt trauma. Rheumatoid arthritis and hyperparathyroidism are associated with erosion of the distal clavicles. Distal clavicles is sharply defined in rheumatoid arthritis and taper to a point, whereas in hyperparathyroidism it's widened and irregular. Primary malignant neoplasm of clavicle include Ewing or osteogenic sarcoma. Sternum. Developmental sternal deformities include pectus excavatum, or what called funnel chest, then pectus carinatum, what called pigeon breast. In pectus excavatum, the sternum is inwardly depressed and the ribs protrude anterior to the sternum, commonly associated with congenital connective tissue disorders such as Marfan syndrome, Poland syndrome, osteogenesis imperfecta, and congenital scoliosis. Most patients are asymptomatic, and radiographically, the characteristic appearance on frontal chest radiograph, the heart is displaced to the left, and combination of depressed of the soft tissue of the anterior chest wall and vertically oriented anterior rib result in loss of the right heart border. Right heart border is lost. The finding on frontal radiograph may be mistakenly attributed to the middle lobe opacification from pneumonia or atelectasis. The typical inward depression of the mid-sternum and lower sternum is seen on lateral chest radiograph. We can do a lateral chest radiograph to confirm the diagnosis. Here we have the inward depression of the lower sternum and mid-sternum. CT help define the deformity and its effect upon the heart and mediastinal structure. Pectus carinatum is outward bowing of the sternum that may be congenital or acquired. The congenital is seen more commonly in boys and in families with a history of chest wall deformity or scoliosis. Diaphragm. Eventration of the diaphragm is a result of congenital absence of the underdevelopment of the diaphragmatic musculature. This produced a localized elevation of the anterior medial portion of the hemidiaphragm on frontal radiograph in older individual, which is indistinguishable on the right from rare foramen Morgagni hernia. Complete diaphragmatic eventration is usually left-sided and is indistinguishable from diaphragmatic paralysis. Unilateral diaphragmatic paralysis is usually caused by surgical injury, neoplastic involvement of the phrenic nerve, which affect the right and left equally. Idiopathic phrenic nerve dysfunction resulting from viral neuritis is common cause of diaphragmatic paralysis in male patient and is usually right-sided. A positive fluoroscopic or ultrasonographic sniff test, paradoxical superior involvement of the diaphragm with sniffing, a result of effect of negative intrathoracic pressure on flaccid diaphragm during inspiration, is diagnostic. Chronic loss of the lung volume, particularly from collapse or resection of the lower lobes, result in diaphragmatic elevation. An enlarged liver or hepatic mass can produce right high diaphragm. Also, enlarged spleen and gas-distended stomach can cause high left diaphragm. Eventration of the diaphragm. PA and lateral chest radiograph in an asymptomatic 61-year-old woman reveal marked elevation of the left hemidiaphragm. It's called eventration. Bilateral elevation, this not effort related, may be caused by neuromuscular disturbance or intrathoracic or intra-abdominal disease. The diaphragm are elevated on both frontal and lateral view. Bilateral phrenic nerve disruption or intrinsic diaphragmatic muscular disease will produce bilateral diaphragmatic paralysis and elevation. Common disorder includes cervical cord injury, multiple sclerosis, and myopathy associated with SLE. In this patient, fluoroscopic or real-time ultrasound demonstrate a positive sniff test. We have another subject, diaphragmatic depression and flattening of one hemidiaphragm is seen with unilateral overinflation of a lung, usually as a compensatory mechanism when the contralateral lung is small or as a result of large ipsilateral pneumothorax. Distinction between these two entities is usually possible by clinical history and characteristic finding when we see the pneumothorax. Diaphragmatic hernia, we have three types of hernia: esophageal hiatal hernia, which represent herniation of portion of the stomach through esophageal hiatus, usually incidental, asymptomatic, and seen projecting behind the heart on frontal chest radiograph in immediate supradiaphragmatic region of the posterior mediastinum. Air fluid level may be seen, and CT show widening of the esophageal hiatus, and we can see content of the sac. We have bogdalic hernia. It's defect in the hemidiaphragm at the side of the embryonic pleuroperitoneal canal. It is mostly on the left side because of the protective effects of the liver on the right side. The typical hernia appears as a posterior lateral mass above the left hemidiaphragm, and CT shows the diaphragmatic defect with herniation of the retroperitoneal fat, omentum, spleen, or kidney. Morgagni hernia is a defect in the parasternal portion of the diaphragm, and foramen of Morgagni is the least common type of diaphragmatic hernia. It's mostly right-sided and appears as asymptomatic cardiophrenic angle mass, diagnosed by noting herniation of omental fat, liver, or transverse colon through the paracardiac portion of the right hemidiaphragm. Traumatic hernia, it is 90% left-sided because liver protects the right hemidiaphragm, and we should suspect it when there is left hemidiaphragm indistinct or elevated, or when gas loop bowel found in the left lower thorax following trauma. Diaphragmatic tumor, primary tumor, are rare with equal incidence of benign and malignant lesion. Benign include lipoma, fibroma, schwannoma, and fibrosarcoma are the most common primary malignant diaphragmatic lesion. Congenital lung disease, we have bronchogenic cyst, we have congenital cystic adenomatoid malformation. It's usually seen in newborn infant and appear as around air-filled masses which exert mass effect on the adjacent lung and mediastinum. If it's seen in the left lower lobe, may be difficult to distinguish from congenital diaphragmatic hernia. Bronchial atresia, a developmental stenosis of a lobar or segmental bronchus, produce bronchial obstruction with distal bronchiectasis. Here we have a 43-year-old woman with a history of asthma. We see a curvy linear opacity in the lower right lung, and in the CT, coronary formatted through the posterior thorax at lung window show a hyperlucent portion of the right lower lobe within which there is a broad tubular opacity representing bronchioceal in a patient with bronchial atresia. Neonatal lobar hyperinflation or congenital lobar emphysema may develop from a variety of disorders that produce a check valve bronchial obstruction, and it's mostly occur in the left upper lobe, then right middle lobe, and then right upper lobe. We see hyperlucency of the affected lobe with compression of the adjacent lung and diaphragm with mediastinal shift. Bronchopulmonary sequestration, we have intralobar and extralobar sequestration. Intralobar, most patients present with pneumonia, and extralobar, it is asymptomatic, incidentally finding. The intralobar contained within the visceral pleura of the normal lung, while the extralobar enclosed by its own visceral pleura envelope and may be found adjacent to the normal lung or within or below the diaphragm. Found in the lower lobes in 1/3, it's right-sided. The intralobar is right-sided, while found in the lower lobes and left-sided in 90%. The extralobar. The intralobar supplied by a large artery that arises from the infradiaphragmatic aorta and enters the sequestrated lung via the pulmonary ligament, while the extralobar receives several small branches from systemic and occasionally pulmonary artery. Hypoplastic lung. One example of hypoplastic lung, we have hypogenetic lung scimitar syndrome. It's underdeveloped right lung with abnormal venous drainage of the lung to the inferior vena cava just above or below the right hemidiaphragm. Systemic drainage of the lung produced extracardiac left to right shunt. And frontal chest radiograph will show a small right hemithorax with diaphragmatic elevation, eventration or dextroposition of the heart, and herniation of the left lung anteriorly. This example of scimitar syndrome. We see small right lung. Atriovenous malformation are abnormal vascular mass in which focal collection of congenital buccal capillary dilate to become a tortuous complex vessel. They are seen as solitary pulmonary nodule, most often located in the subpleural portion of the lower lobes. 1/3 of patients have multiple lesions. Traumatic lung disease, we have pulmonary contusion, which appear in the first 12 hours of the trauma and stabilize by 24 hours, resolve 2 to 7 days. This is contusion. Laceration, we have traumatic lung cyst and pulmonary hematoma. Laceration lead to formation of a round air cyst due to the elastic properties of the lung. On radiograph and CT, these cysts appears a round lucency that may contain air or air fluid level, and they shrink over weeks to months. Aspiration pneumonia, pneumonitis describe mixed anaerobic infection resulting from aspiration of infected oropharyngeal content. Radiographically appear as bilateral, extensive opacification, diffuse but discrete airspace, nodular opacity, and irregular parenchymal opacity that are not obviously airspace filling in nature. They are bilateral and mostly in the basal. Exogenous lipoid pneumonia, multifocal areas of consolidation or mass can result from aspiration of lipid material and are classically seen in older patients. Radiation-induced lung disease, last subject. Most radiation treatment is limited to less than 1/3 to 1/2 of lung. Those under 20 rarely produce lung injury, but if it exceeds 30, it will and if to significant portion of the lung, it will have significant effect of radiation pneumonitis. This change develop 4 to 12 weeks following the completion of the therapy. It means after 1 month. Here we have radiation fibrosis in X-ray and CT.